is our low dose, our medium dose, and our high dose, and the percent change corrected for placebo. Now, placebo effect is pulled out. And I've compared it to the study that Barbara, I'm sure, told you about, which is the TAC study, which used, in our parlance, about equal to our medium dose. So your point about using lowish doses in Tourette probably makes sense. And then the MTA. And again, this is roughly corrected for placebo. So you could see that the kids in our study, there's a hint of a dose response here. It's not big, but the effect is not as big as in the MTA. So we shouldn't expect big effects when using these drugs, and we're talking low doses. Tolerability, 7 of the 66 children exited because of an adverse effect. Now in the MTA they had the number that had to exit because of adverse effects was in the 1 or 2% range. So this is a big difference, And irritability was the most common reason for discontinuation. There were lots of other adverse effects. Increased stereotypy, obviously problems with insomnia, problems with appetite, but for discontinuation it was irritability. What do I mean by that? Crabby, cranky tantrums. So at low doses, this could be, you know, part of your direction if you want. At low doses, and I mean low, 12 to 25 per day in a school-age child. It'll help about half the kids that are hyperactive. The amount of improvement, the magnitude, about 20%. You might get a few more extra points if you let the placebo, you know, in other words, there was some benefit from placebo that parents feel like they're doing something about it. You might get a little more, but it's not 40%, it's not 50% like we'd expect in typically developing children. It will be less tolerated reasonably well at low doses. If you bring to the table a mindset of treating ADHD and you push to get more out of it, you probably won't. So we did a study. We took the kids who came to the study and otherwise would have been eligible, but they had recently failed stimulant trial. Or the kids who bombed out of our trial, we put into an open label study of guanfacine. So this is open label, but these are kids that have been through a filter, pretty big one, of failing methylphenidate. The number was 25. You see they're a little older, mostly boys as you would expect. Whereas our methylphenidate group had predominantly autistic disorder, this was more PDD NOS. So we use the same outcome measure as we used in the methylphenidate study. This is a measure that's been used a lot in the PDD population. And you can see that on the last to the right column, second to the last, is the change score. Now this, no placebo. No placebo, so there's no correction for placebo. You know, this is certainly rivaling what we saw with the methylphenidate, and these are all kids that failed methylphenidate. There were a lot of adverse effects. This paper is out there, so you can read it in detail, but I want to make one particular point. Sedation you'd expect. It's related to how quickly you increase the dose. If you go slow, it's usually not a big problem. But the mid-sleep awakening, we see that with clonidine in Tourette. It's sort of an issue that comes up reasonably often. More so with clonidine than guanfacine in Tourette. So here we're seeing it as a fairly common adverse effect in this group, 6 out of the 25. And in many cases, it meant that the kid had to go off the drug. You could not steer your way around it. In some cases, strangely enough, we were taking away the nighttime dose because my simple mind about this came from experience with clonidine. that the drug has a soporific effect at peak, and then it wears off, and the kid wakes up. It's a little harder to lay that pharmacokinetic story on guanfacine, but we operated as if it was the same sort of thing, and oftentimes taking away the nighttime dose. But it was a somewhat surprising adverse effect because we don't see it so often in kids with Tourette. So these data are obviously no placebo, and it's a specialized group of kids, but I'd call encouraging. Based on the past studies with clonidine, this looks to be better tolerated. They're at higher risk for adverse effects once again. And I really believe that the next study that we do should be a dose-finding study. I don't know if we'll ever get the funds to do it, but that's what needs to happen. This is more sort of my, my little algorithm of how I look at this. So methylphenidate, I think we have pretty good evidence for efficacy. Realizing that the effect size is not large, but the results, I think, are there. So, and at low doses, tolerability is okay. Atomoxetine, I only put a 1+ there because of the status of the data, and I didn't go into it, but there are 2 studies that have been published that have a placebo. They're not overwhelmingly convincing, but they're both small studies, and both of them suggest that there's a signal there. So I would call it small to medium effect again, and tolerability is okay, although you probably talked about what to watch out for in there. Clonidine, it hasn't been well studied, but it just doesn't look like it's very well tolerated in this particular group. I do have some kids on this, but it's not usually the first thing I go to because of the sedative effects and the ups and downs. Guanfacine, we've had a lot of experience with it. I think it's a useful medication, and the tolerability is something to watch out for. These are adverse effects that you got to steer around. They're not big concerns medically. Amantadine has not been well studied. The study that is out there is an N of 40 with the placebo control. It showed no clear benefit for hyperactivity, but there are some funny design problems with the study. So I'd have to say we don't know. I've used it in a few kids. Once in a while it seems to work. I don't have any idea for whom. So I wouldn't put it very high on any list that anybody should try, at least not now. Naltrexone, forget it. It's been studied. There are some people that have continued trying to show that this drug had benefit. Most of those studies go back 15 years. There just doesn't appear to be anything there. SSRIs. I have the S because clomipramine, but I'm not going to talk about clomipramine. The rationale seemed to be that there was some connection with the repetitive behavior, the rigidity, the insistence on routines, some kind of package like that that was similar to OCD. And that led people to use the SSRIs. They are the most prescribed drug in this population. So what do you think? Compulsive behavior in children with autism is the same as it is in OCD? B, compulsive behavior in autism involves behavior that the kid wants to do. They want to watch that Barney tape another 10 times. They want to watch that Thomas the Tank Engine thing another 10 times. The problem comes in when you try to stop them from doing it. So it seems to be a horse of a different color, but no matter. So going back to this little report card here, one study, more than 40. Most of the studies that have been published are open label. Some of them, I hate to say it, are chart reviews that did not stop the authors from making tremendous claims on the value of these drugs. What have we learned so far? We've learned that these drugs don't have big medical adverse effects in this population, but they have plenty of problems with activation. And we call it activation. It's a package deal. I often believe that insomnia is the first peak at this thing. But if you miss it, it's going to get worse.